Welcome to the Diabetes Podcast, where we rewrite the story of diabetes. If you're ready to break free from the guilt, the medication, and the fear of complications, you're in the right place. Each episode is packed with real talk, proven strategies, and inspiring wins from people just like you. Yes, remission from type 2 and prediabetes is real, and it starts right now. Let's get into it. Hello, I'm Richie.
And I'm Amber.
And Amber, another good day. We got another good day. In fact, as it relates to our podcast, I think this is the best day so far because today we're talking about increased insulin resistance in the muscles. So to catch you guys up, this is part 3 of 12, which we call Anything Meds Can Do, You Can Do Better. And this is a big one today. So let's get right into it. Before we can talk about increased insulin resistance in the muscles, I think we probably need to talk about just what is insulin and what is it doing in my body?
Yeah, absolutely. So when we think about what insulin does, it does so many things. So it's important to really understand that insulin is a hormone made by your pancreas, and its main job is to function as a key that unlocks the door to your body's cells and lets glucose, which is the broken down form of carbohydrate, so glucose, fructose, lactose, galactose, all those words that end in ose, your carbohydrate containing foods, helps them get into the cells where energy can be used by your body for all of the things that you do, breathing, moving, living.
So for the, let's just say, layman like myself, what we're talking about is getting sugar out of the bloodstream and into the cells where it needs to be.
Exactly.
Okay.
Mm-hmm. That's a great point to make because when sugar levels build up in the bloodstream too high, that's a major issue that's going on with diabetes. So very good thing to point out.
Okay.
Mm-hmm. When we talk more about what insulin does, it really says, hey, muscle cells, fat cells, liver, open up. I got some, here comes the plane, open up your mouth to the little kid, and either when the glucose goes inside, it's either used to make energy right then and there, or it's stored for later. This is why we don't have to eat 24/7. We have a liver where that glucose can go for storage. And that is called glycogen, or either it's stored as fat.
So if it's going into the liver, it's getting stored, and pretty much everywhere else is just getting used up kind of as needed. Is that right?
It could also get converted and stored in the fat cells as well.
Okay.
If you have more glucose than the body needs right now, it can either store it in the liver, muscle, or fat cells.
Okay.
Yeah. And another thing insulin does is it stops the liver from pumping out sugar. So when insulin is working, it tells the liver, hey, we've got enough sugar right now. Chill out. You don't need to make any new glucose. And then lastly, it prevents fat breakdown. So high insulin levels equal storage mode. High insulin levels say hold on to fat, and it's much harder to burn fat. And that's why high insulin levels across time could increase weight gain.
All right. What is it that's causing these high insulin levels?
So the root cause is usually insulin resistance. If the key is having trouble fitting the lock, because remember, insulin is the key that unlocks the body's cells. If you've got think of a key to your house that's 15 years old, sometimes that key gets worn down and it's hard to turn it and get in there. Or if somebody came along and shoved a bunch of Crisco in the lock, it could gunk it up. And so the insulin is having trouble unlocking the door to the body cells and letting the energy, the glucose, get inside, and it just doesn't respond that well to the insulin. And the compensation effect is the signaling to make or to produce more insulin, have the pancreas put out more insulin. And what can cause this, like the root cause of insulin resistance, is either a mix of too much energy meaning you're eating a lot of refined carbs and usually these like highly processed foods would be white bread, sugar, sugary drinks, and sometimes these convenience foods tend to have more fat and saturated fat as well. And another thing could be not enough energy getting used up. In other words, a sedentary lifestyle. Another is visceral fat, so where you store fat in your body, which can have a genetic effect. Are you more of an apple body type? When you think of someone with larger hips but a smaller waist, that person is less prone to insulin resistance than someone who stores the majority of their fat around their abdomen, around their midsection and liver and their visceral organs, you would say. So the organs all around your lungs, heart, liver, intestines, in that area. And lastly is poor sleep, chronic stress. These things can increase cortisol, and that decreases your body's sensitivity to insulin.
Okay. If I can loop back to something that you'd said previously about how insulin discourages fat utilization for energy, is it safe to say if my insulin levels are increased, if they're higher than they should be, that my body is effectively in professional fat accumulation mode?
I think that would be safe enough to say. It's definitely harder to lose fat when you have higher circulating insulin levels and insulin resistance. Yes.
Okay. So when, particularly speaking to the portion of our listeners who have elevated insulin and are really struggling to get rid of some of that fat, is it fair to say insulin resistance is probably a big component of why that's so hard, because just having elevated insulin is a nonstop signal to my body to not burn fat. Is that accurate?
I wouldn't say to not burn fat, but it's not as effective
to store energy as fat. Yeah. Yep. All right. We talked about what insulin is. We talked a little bit about insulin resistance. How do I know that I have insulin resistance? Is there a test that I can do or something? How do I find out?
Yeah, it's a great question, because this is oftentimes going on behind the scenes, and there's nothing really overt that would have you feeling any differently. Like, this is going on at the cellular level. There's nothing screaming you have hyperinsulinemia, or which is just higher insulin levels in the blood. There's nothing alerting you to that. So you can ask your doctor to get a test run, and this is called a fasting insulin test. It measures the amount of insulin in your blood about 8 to 12 hours of fasting. So not having any food for about 8 to 12 hours and then going in and doing it. So if these fasting insulin levels are greater than like 10 to 12 microunits per milliliter, that's a red flag for insulin resistance.
Just real quick, this is probably the only thing I've seen that the VA does real well, is they always have me do my blood test before I actually talk to my physician. So we talk about my blood test at every conversation I have with my primary care doctor, but I don't think I've ever had the fasting insulin test. Is there a reason that more doctors aren't doing this test?
That's a great question. I think it's something that some physicians are becoming more aware of and ordering this. I think if we're looking at the cons of this test, there's really poor standardization between labs. So if you're going to run a test, it's important that you can speak to the results with your patients. And if physicians aren't prepared to talk about this, they might not see it as something that they want to order. It's not in your basic metabolic panel and your basic lab test. It would be an add-on to that. It's also that these high insulin levels can fluctuate day to day due to stress, sleep, exercise. If you had a really stressful exercise day and then you went in and had this test, it could show elevated insulin levels. And it's only showing a snapshot in time. It's not showing the post-meal response either, because you're going in fasted. And a lot of times it's that post-meal response that's very problematic. But
So it's not like my A1C where it's this long lagging indicator of where I've been for 3 months effectively. So this is much more near term to when the test is actually conducted.
Yeah, much faster, because by the time you have, say, a 6.5 A1C, which is the diagnosable A1C for diabetes, it's often years of your pancreas in overdrive, pumping out insulin to overcome this resistance. And according to metabolic researchers, this high insulin levels in the blood, these can be present for 10 to 20 years before a diagnosis of type 2 diabetes.
So again, just want to be real clear.
Yeah.
20 years?
10 to 20 years before a diabetes diagnosis, you can see these problems before a fasting glucose level, before an A1C level changes at all. And this test is really cheap and widely available.
We're not talking 50s and 60s population. We're talking 40s, 30s. When is it appropriate to start looking at this kind of stuff?
I would say it's appropriate whenever you're concerned about excess fat around your midsection. If you're concerned about a family history, if your mom and dad, grandparents all have type 2 diabetes, it would make sense to get this test.
Okay.
And like you were saying, you can be metabolically unwell for years before your blood sugar crosses that level that's considered the diabetic threshold, because you can, so what that number is for diagnosing type 2 diabetes, it's an anytime blood sugar greater than 200 plus symptoms. So are you feeling tired, lethargic? Are you peeing often? All those signs there. Or a fasting blood sugar that's 126 or higher.
Does A1C factor into your diagnosis?
Yeah, I mean, if your A1C comes back 6.5 or higher, that's diagnosable for type 2. Yes.
Okay.
Yep. And I think what I would love for people to understand is that it's not only these high circulating insulin levels and sugars being higher in the blood, because this could be going on before you notice higher sugars, before you notice a higher A1C. There's this metabolic syndrome, this metabolic ripple effect. If you threw a stone in the water, it ripples out all the way around. And because insulin normally suppresses this release of fat that you were speaking to earlier, these free fatty acids, when you have insulin resistance, this suppression doesn't work very well. And your fat cells can get leaky, and they leak more of these free fatty acids into the bloodstream. And then the liver comes in and says, let me fix this mess, and takes these free fatty acids and repackages them into triglycerides, and then sends it back out into circulation in these really dense packages called very low density lipoproteins. And these are more damaging.
Can you talk a little bit about very low density lipoprotein? I've heard HDL, which mine's not great, full disclosure.
Oh, I am disclosed. I'm aware of your.
And I've heard of LDL. I've never heard of VLDL. Can you talk a little bit about that?
Yes. And I will say your HDL, it definitely has a genetic component. Your dad's HDL was really low. And so there's a genetic piece to that, but there are definitely things that we can do beyond genetics. Yeah, so going to VLDL, these really small, dense packages, the reason they're so damaging is that they can squeeze into the blood vessel walls and they oxidize. So if you think of a rusty chair left out in the rain, that oxidation is how the arterial plaques can form, because the body's like, ooh, that's a rusty, jagged area, and it covers them up with more of the blood vessel wall. And people think that's how a heart attack happens, that you get plaques and it covers over and plaques and covers over. But it's more sticky in that area. If you were to have a cut and bleed, your body has clotting factors, and those clotting factors can stick to those areas, and you throw a clot, which can be more dangerous. But it even affects the high density lipoproteins, those HDLs that you were talking about, because those excess triglycerides that the liver makes, it really changes the normal recycling and functioning of the HDL particles, and they make our good cholesterol less stable and easier to clear out of the bloodstream, like we want them in the bloodstream, because they are the cleanup crew. So insulin resistance creates a situation where visceral fat, which is this metabolically active fat cells, send out chemical signals that make your body more inflamed. And the greater the visceral fat, the greater the insulin resistance. And it just becomes this kind of snowball effect, this vicious cycle of a toxic environment in and around your internal organs of inflammation.
Just so I understand, my fat's sending out signals now?
Yes, your fat is metabolically active tissue, and it has the ability to do that.
Okay.
Yeah. And I think that brings us to another important point, something that Ralph DeFranzo, we've mentioned many times. He has said that skeletal muscle is responsible for 80% of glucose uptake in the post-meal state.
Okay. I feel it's appropriate to pause here and really hammer that home. Muscular uptake of glucose or sugar, the ability to get sugar out of the bloodstream and into my muscles, is 80% of this blood glucose equation.
Yes.
Okay. So just
80%
dumb this down, even
that
like
can be taken in by the skeletal muscle.
If I get
post-meal glucose.
If I have, of these 12 deficiencies, if I want to really focus on getting one thing right, it's this right here. It's getting the glucose out of my bloodstream and into my muscles, and whatever I got to do to make that happen. Is that fair?
Mm-hmm.
Okay.
Yeah. So I'll help with that. If you imagine your muscles as bustling factories, each factory has a security gate that controls the entry of sugar from your bloodstream. And under normal circumstances, you've got your insulin key that unlocks the gates, allowing the glucose to enter the cell and be used for energy. But what happens when the key doesn't work properly, as in insulin resistance, and you've got these faulty locks again, and the glucose struggles to enter the muscle cells? Then you have elevated blood sugar levels.
Right.
And here's really where the body showcases its remarkable ability to adapt. During physical activity, your muscles have an alternative method to access glucose. So there is no key required for your muscles to take in glucose when you engage in exercise. Because when you exercise, your muscles contract, they squeeze, and they signal an increased demand for energy. And this contraction activates a special energy sensor within the muscle cells. And this is called AMPK, which is activated protein kinase. So you can think of AMPK as an internal alarm that alerts the cell factory to ramp up energy production. And then AMPK initiates the movement of something called GLUT4 transporters. These are the gateways for glucose.
Okay,
and
so they have nothing to do with my glutes.
They have nothing to do, well, I mean, if these GLUT4 transporters
unless my glutes are working.
in your glute, So they're trying to get these GLUT4 transporters up towards the cell surface. So it's like opening additional doors in the cell factory to allow more glucose in, independent of insulin. So if you've got these GLUT4 transporters up at the top, and what can help get those up towards the top is something called RAC1. It's a molecule that assists in reorganizing the cell's internal structure to facilitate that movement of those transporters up to the surface. So between the signaling of AMPK and RAC1, it ensures that your muscles receive the glucose they need during exercise, even when insulin isn't being very effective at doing its job. Additionally, exercise enhances blood flow to the muscles, ensuring a steady supply of glucose or energy, and it boosts the activity of the mitochondria. And if you remember, what are mitochondria, Richie?
Those are my power plants of my cells.
Yes. So they're getting more activity in that power plant, and that further improves your body's ability to make energy and access it. So what's truly fascinating is that this insulin-independent pathway can remain active for up to 48 hours and help your body take glucose in without insulin and even be more sensitive to insulin for 48 hours.
I just want to make sure I understood that correctly.
Yeah.
This alternative pathway to getting glucose into my muscles, to me it sounds like exercise. If I'm reading it. Muscle contraction, whatever that be. This mechanism can continue to function for up to 48 hours after I stop exercising?
Correcto.
Okay.
And here's an interesting story around that. In all the years of counseling people who have diabetes, I looked at someone's blood sugar records once before continuous glucose monitors were really in use for most people. This person checked their blood sugar religiously before every meal, many times after a meal. So they were checking like 6 times a day finger sticks, like really incredible logging of their blood sugars. And the blood sugars were beautiful. They were 70 to 110 pre-meal, 90% of the time. Their post-meal blood sugars were under 140, 90 to 100% of the time, like really beautiful blood sugars. And they walked for more than 30 minutes, like 30 minutes to an hour every other day. And then there was a day in there that looked like hot garbage. It was like the blood sugars, the fastings were high and it just stayed high all day. And the post meals got up to like 220. And I'm sorry, that's not necessarily hot garbage, but compared to...
It was an outlier.
Yes.
It was, everything's looking great, and then I got a weird day. What happened? Right.
Yes, absolute outlier. So I'm like, what happened here? Was your meter broken? What's going on? And so he walked that long every other day. And on that day that was crazy, he had not, let's say that was Monday that he walked.
Right.
And Tuesday, and then Wednesday, normally he would have walked. This was Wednesday, and he did not walk.
So that was that end of the 48-hour tapering off there. Wow, that's something.
It was, and he didn't walk Thursday either. He had some kind of conference, something going on. Right. But like for 2 days, he didn't walk, and the blood sugars were horrific. And that sold me right there. From that point forward, I knew. I always knew, but you don't know
until you see it.
Exactly, until you see it. So what's really cool, I want to highlight some studies in this area. There was an article in the journal in Nutrients that said just a 30-minute brisk walk can significantly reduce post-meal blood sugar spikes, like how far it goes, regardless of the carb content of the meal. So you eat a bunch of donuts, not that I'm recommending, but like whatever it was.
But I could.
It did not matter. It significantly reduced the post-meal peaks. So the highest of the high was not as high. And then in the journal Sports Medicine, even 2 to 5, this is what's crazy to me, 2 to 5 minutes of light walking after a meal can improve blood sugar levels.
Wait, one more time?
even 2 to 5 minutes of light walking after a meal can improve blood sugar levels, is what was shown in that study.
So when I hear that, I geek out a little bit.
Yeah.
If I haven't spoke to
Geek
it
out.
before, I'm a big James Clear fan, and he's all about creating new habits. And
I am too.
one of the biggest indicators of success as far as creating a new habit is whatever it is, the new thing that you're trying to do, shoot for it taking at or less than 2 minutes. So when you're telling me that even 2 minutes of activity after a meal can bring my blood glucose down, I'm going to ask a leading question. Who should not be walking or moving for at least 2 minutes after a meal?
Nobody.
So this behavior,
Nobody.
minimum 2 minutes up to 30 minutes after a meal, is appropriate for all humans.
Pretty much, yep.
Okay, right. Just wanted to really hammer that home.
Yeah, and then I'm going to just add one more on there. In the journal, the Diabetologia. Diabetologia.
I don't think that's a word.
I'm telling you, that's the name of the publication. Anyway, individuals with type 2 who walked for 10 minutes after each of their main meals was more effective at lowering their post-meal blood sugar levels than one single 30-minute walk at any other time of day.
So what that says to me, if I understand that correctly, is I don't want to jam my activity in first thing in the morning. That would be better than nothing. But if I really want to get the most effect out of this movement, pulling sugar out of my bloodstream, it's better to space it out, and particularly space it out following stuff going in my mouth. Is that right?
Yeah, the timing after meals is absolutely crucial to keep the high spikes after a meal controlled.
This is, wow, okay.
And that keeps the circulating insulin levels lower. That keeps the triglycerides lower even. And we talked a bit about the damage that the triglycerides can do.
All right, Amber, I'm going to pause you there. This one seems to be running a little bit long. I know that this is a huge topic to cover, but I just want to make sure that we cover everything. So we are going to pick this up next time. And next time we're going to be talking about the medications used to treat insulin resistance in muscles, as well as some of the negative downsides of those medicines. And again, we're really going to get into things that you can do to make this better on your own.
All right.
Okay. So we'll see you next time when we pick up part 2 of increased insulin resistance in the muscles.
All right.
Thanks for tuning in to the Diabetes Podcast, where diabetes doesn't define your future. If you liked what you heard, please share this episode and leave a review. If you want to hear more, please subscribe to hear the latest episodes. And if you're ready to take the next step towards freedom and energy, head to empowerdiabetes.com to learn how we support real change with real results. Your healthiest chapter starts now. Take courage. You can do this, and we can help.